Good afternoon and welcome to our PHSSR Research in Progress Series webinar. Today's general theme is Public Health Cost, Quality, and Value. Our topic today is investigating characteristics of tribal public health system organization and performance. Our presenter today is Julia Heany, PhD at the Center for Healthy Communities in the Michigan Public Health Institute. Dr. Heany is the principal investigator for this study, which essentially explores a tribal public health agency's organization, capacity, and ability to fulfill the essential public health services. He's also been involved in numerous other projects looking at collaboration with tribal public health or tribal health agencies. So, Julie, would you like to go ahead and get us started?
Yes, thank you, Rick.
Great.
And thank you everyone for joining the call today. I look forward to sharing some early results of our study this afternoon or this morning, I'm sure, for some of you, and hearing back from you on what some of your takeaways are and questions are on what we've done. I'd first like to acknowledge our study team here at MPHI. We have Shannon Lang and Jennifer Torres here in the room, and they've been key to the making the study successful, and the other members of our study team as well have played a really important role in carrying out this work. I also want to acknowledge our partners in this research process, especially the Sault Ste. Marie tribe. They were our case study site and put forth a tremendous amount of effort into carrying out this research and making sure that what we did is meaningful and reflects the work that they do in their community. I also want to recognize the Intertribal Council of Michigan, who played a key role for us in serving as a bridge between our group here at Michigan Public Health Institute and the tribe. And I also want to acknowledge and thank our Tribal Advisory Group, which included 9 tribal health researchers, practitioners, and advocates from tribes and tribal organizations across the nation, and whose insight and expertise and experience has been invaluable throughout this research process. And of course, I want to thank the Robert Wood Johnson Foundation Public Health Services and Systems Research Program for their support of this research. Today, I'm going to provide a little bit of background on the study, describe our design and methods, present some key findings and future directions. For those of you who might be a little bit less experienced in working in tribal public health, I thought I'd provide just a little bit of a brief background on tribal public health. In the United States, there are 567 federally recognized tribes that have a government-to-government relationship with the U.S. They are sovereign nations. And the U.S. government has a trust responsibility in their relationship with the tribes in the country. This trust relationship was established through a long history and a series of treaties through which tribes ceded their land and their natural resources, and in exchange were promised education, health care, and other services. The Indian Health Service within Health and Human Services is responsible for delivering health programs, function services, and activities with tribes. And this includes both health care and public health functions, services, programs, and activities. And this responsibility that IHS has can be shared with tribes through a contract, or it can be assumed by tribes through a compact. So there are several different ways that the U.S. exercises this trust responsibility through IHS with tribes and tribal communities throughout the country. So tribal public health systems themselves are incredibly diverse based on when tribes receive federal recognition, their population size, their cultural beliefs and practices, their governmental structure, their language, their history, and so forth. However, they do share this legacy of the relationship with the U.S. government and the exercise of the U.S. government's responsibility to tribes through the IHS relationship. A little bit about how we came to this study here at the Michigan Public Health Institute Center for Healthy Communities. We, within our center here at MPHI, we conduct participatory evaluation and research with a capacity building, servant leadership sort of orientation to that work. And 2 areas of focus for our program over the past 10 years have been public health system improvement and tribal health and wellness. Through the series of projects that we've had with tribes and in our work in public health system improvement, and especially as public health and accreditation standards have evolved over the past several years, we've noticed some differences in the structure and function between tribal public health agencies that we work with and local public health and state public health agencies that we work with. And we've wondered about the degree to which existing public health models of service delivery adequately or accurately described public health. So that was sort of the impetus for proposing this study. Oopsies. Our work really led us to several questions that we looked to the literature first to answer. We wanted to understand how tribes create conditions in which people can be healthy. We wanted to know more about what public health systems look like in tribal communities. We wanted to understand the role partnerships played in tribal communities' efforts to protect and promote health. And we wanted to understand the extent to which the model of the 10 essential services made sense for tribes. As we looked at the literature, we found some pretty big gaps in our ability to answer these questions from a research perspective. And so we proposed a study to help develop and document evidence that describes how tribes may organize and partner to promote the health of their communities. We entered the study with these aims in mind. We wanted to explore the partnerships within tribal public health systems that protect and promote health. We hope to examine how and through what relationships a tribal public health system delivers the 10 essential public health services. And we wanted to assess the key characteristics of a tribal public health system that address health disparities. We also entered this study with the following model in mind. This is the model that guided our research protocol and the way that we approached the work. What you see here is a modified version of Handler et al.'s conceptual framework of the public health system. And according to this model, the public health system includes four components, which we'll be talking about throughout the rest of the presentation today. The mission, the structural capacity, processes, and outcomes. And you probably can't see on the slide very clearly, but the processes reflect the 10 essential public health services in the Handler et al. Model. We modified this model to better fit the study context that we were going to be working in by integrating within that second component of structural capacity, Cross's concept of the relational worldview model. So this model is based on traditional indigenous ways of knowing, which see and accept complex relationships between the interrelating factors in one circle of life, and this is often pictured as a medicine wheel. And the four quadrants, as we have articulated in this version of the model, are identified as mind, or the intellectual component, body, the physical component, spirit, the spiritual component, the context or social component. So this way of understanding structural capacity guided what we looked for when we went in and collected data with the tribe. We also used the structural constructivist model of understanding health. I'll get my words behind me today. Dressler, and this model emphasizes the importance of taking both a cultural constructivist and a structural approach to understanding health and illness. So what we wanted to do was focus on meaning, and particularly the meaning that people construct to understand and interpret health and illness. So these were sort of the conceptual ideas, frameworks that we went into the study with. We decided that given the limited existing evidence base, we would implement a case study design. We thought that a case study design would give us the deep descriptive information that would be able to provide the field with some guidance on what might be important to explore further within a tribal public health context. The study certainly doesn't provide generalizable information, but instead provides deep descriptive information about the experience of one case study site. The case study site itself was selected by our tribal advisory group through a call for a community research partner process. The case study site itself is in the Bemidji area. It was federally recognized in 1975. The tribe has 14,000 members and a 7-county service area, and most of the service area is rural or very rural. It's a 638 compact tribe with a 12-member elected board of directors and a tribal chairperson. One of the divisions of their government is the health division, which runs 4 clinics, 4 community health centers, and operates a comprehensive set of programs, services, activities, and functions. The methods that we used for our case study included both primary and secondary data. We conducted 50 in-depth interviews with professionals within the tribal public health system. We completed eco maps with 38 individuals who were members of the tribal public health system, and we completed 7 focus groups with different groups within the community. So we had a focus group with elders, a focus group with youth, for example. We also looked at secondary data. The tribe completed the Tribal Public Health Capacity Assessment Questionnaire as one data source for us. They also provided data that was collected through a population-based health survey. We looked at their census data, and we also used a variety of documents, including tribal codes, the tribal constitution, tribal resolutions, the IHS multi-year funding agreement that the tribe has with IHS, and the tribe's strategic plan. Okay, so some of our key findings, and we, with the time limits of the webinar, my goal today is to give you a taste of the breadth of the information that we collected, with the hope that you'll find it engaging enough that you'll want to dive into different pieces of this research as we release more information about what we learned. So this is just sort of a starting point at a high level of what we discovered. So in understanding the tribal public health system's mission and purpose, what we heard from participants was that public health system partners define the purpose of public health in a fairly consistent way. They talked about prevention, they talked about educating and informing, they talked about providing safety net care, working together across partners to protect and promote health, and they talked about community health and wellness. What we really heard was that there's a shared mission and goals across partners around making the healthy choice the easy choice, providing integrated and community-based services, and preserving culture and traditions. The mission and purpose of the tribal public health system can't be understood without looking at their relationship with IHS and their IHS compact. So within their IHS compact, they formally establish their responsibility for health in terms of the program, services, functions, and activities that include public health interventions. They also have within their tribal code 11 chapters that are public health related and 15 additional chapters that have some impact on health. We asked partners and community members both to tell us about what they believed the tribe was responsible for when it came to public health, and we heard that partners within the public health system believe the tribe was responsible for protecting and promoting health, assuring equitable access, ensuring cultural and traditional practices, making health a top priority, and health education. Community members had something similar to say, but with a different sort of lens to it. They articulated the tribe's responsibility as being to listen to the elders, to improve current programs, to engage young people, and to support individual and collective well-being. In order to understand the how and why of service delivery, the model that we came into this with suggested we needed to understand the structural capacity of the public health system. Again, we used the relational worldview model to explore the tribe's structural capacity, and this slide highlights a little of what we learned about the key factors in the context or the environment. Within the context, we heard about 4 factors in particular that shaped what the public health system does and how it functions. We heard a lot about the history of the tribe. The programs and services that IHS directed its limited resources toward have become sort of hallmarks of what the health division's work focuses on. So they focus on things like infectious disease control, monitoring environmental health hazards, especially providing clinical care and health education, which reflects sort of where IHS's priorities have landed over the years. We also heard a lot about the impact of geography and climate. They have a 7-county service area, which is a large area to cover, and much of it is rural, which creates challenges for service delivery. They also face a lot of cold and a lot of snow up north where they are that create barriers to access as well. They have challenges getting transportation systems in place that really meet folks' needs. They also are challenged by figuring out where to locate clinics and services that are place-based when they have such a large geographic area to cover. We heard about the role of social norms in creating the environment in which the public health system operates. Elders, for example, told us about how traditional ways that protect health have been lost. They talked about hunting and fishing, for example, as a way that they learned to take care of themselves growing up that children now aren't learning as much about. And they also talked about how pervasive their forces and behaviors are that hurt health. They talked about things like the availability of processed food and fast food, for example. As another example, we heard from youth about how normal alcohol and drug use have become, from their perspective, within their community. So some of those social norms create a feature of the environment that has an impact on how health is delivered and how health care and public health are delivered. We also heard about the economy, the regional economy and the economic status of the population impacted programs, services, and health status. The spirit of the community was also a core component of its structural capacity and helped us understand the services that were delivered by the tribe. We saw that cultural beliefs and practices influenced what the community needed and how the health division and its partners responded to those needs. We saw the capacity of the tribe to incorporate culture and tailor services across tribal divisions and programs. It was really a hallmark of how staff approached their work, and it was an expectation of community members. We heard the message that traditional ways are healthy quite a lot, and we also heard the message that programs are more effective when they reflect the tribe's culture. However, we also noted that non-tribal public health system partners seem to have less capacity or comfort with the idea of integrating culture into services and programs. Resources, and particularly gaps in resources, were a key feature of the tribal public health system's structural capacity as well. Both tribal and non-tribal partners highlighted key actors within the tribal public health system that played a powerful leadership role in shaping the system and the services that it delivered. In particular, the board and the tribal community health program were identified as important key actors or key players within the system, as were specific leaders within those environments. There was a real recognition that staff and their experience and expertise were a resource. However, there was a lot of concern expressed by interview participants, especially over staff shortages and turnover, which impacted service delivery in a variety of important ways, limiting services, limiting collaboration or the capacity to collaborate, and interrupting patient care in some cases. It also resulted in lost individual relationships that we heard sort of again and again were the foundation of some public health activities, that activities were created or delivered because two people had a specific relationship. One of the key resources that shaped service delivery was a knowledge of what worked in public health within the tribe and within the different communities within the tribe service area. We heard a lot about how what works in one place isn't necessarily what's going to work in another place within the service area of the tribe. And this capacity to adapt and create based on the local environment and the culture certainly shapes service delivery, and as well as how participants really understood what quality in service delivery means and what it looks like. Finally, the tribe's public health infrastructure was a component of its structural capacity that shaped service delivery. And we have quite a lot of data in this particular area, and I'm going to gloss over a lot of it. Two of the important features of the infrastructure for the tribe were jurisdiction and self-governance. The tribe operates in a very complicated jurisdictional environment, so they're crossing certainly county lines, township lines, intermediate school district lines, town lines. There's an international border. There's their relationship with the state and the federal government, of course, as well. And what we heard was that it was often under the pressure of a specific event that some of those complex jurisdictional issues had to be sort of sorted out and resolved as they occurred. Self-governance is its own webinar topic. I'm not sure that I can, well, I know that I can't adequately cover what I learned, but I do want to say that I think that it was critical for us to understand the role of elected tribal leaders in shaping public health system activities, programs, services, that they play a very direct and hands-on important role in shaping what public health looks like within the tribe. Funding was something also that we heard a lot about, a component of infrastructure. And these two quotes, I think, really summarize what we heard about funding in terms of both the inadequacy of funding levels through IHS and the challenge of funding public health activities through competitive grants. So the first quote, that whole component of prevention services has to be made up somewhere else with the limited funding we have, because we don't receive a lot of Indian Health Service funding. You would receive a little bit for prevention. And then the second quote, it seems like with every grant there's a new focus, or not always new, you know, but maybe it's the same but done in a different way. And then when that grant's finished, it's kind of like everything just stops and the focus is lost. And it seems like to me, you know, a lot of times you feel like you're leaving people in the dust. Those were sort of two sentiments around public health funding that we heard quite a bit. Partnerships were an absolutely critical role in delivering public health services for the tribe. We regularly heard the sentiment or idea that nothing happens or nothing could happen without engaging partners within this community, that it takes a group of partners to carry out core public health activities and services. So three of the themes that we heard around partnerships were that formal relationships between tribal and non-tribal agencies were complicated, and that personal relationships were paramount to success. So again and again, we heard that idea that it was the personal relationships between individuals within the system that created the foundation for successfully delivering programs and services. We heard lots of examples of success and accomplishments that happened because of and through collaboration. And there was also a high degree of integration between not just tribal health care and public health services, which we expected because of the way the tribe is funded, but we also heard about many examples of coordination and almost to the point of integration between health services and other non-health services for clients among tribal departments in particular. So with early childhood and health, there's a very close relationship where services are connected around the needs of families with young children. We, as mentioned, used eco-mapping, and I'm going to present just kind of highlights of what we learned from those eco-maps about partnerships as a component of the tribe's public health infrastructure. So we looked at partnerships, again, through eco-mapping, and through our interviews, we identified 319 individuals who represented 20 sectors that made up the public health system. 57% of those partners were from tribal organizations and 43% were from non-tribal organizations. What we saw through the network analysis was that on average, any person in the network could reach any other person by going through 3 people. We saw a higher degree of density within the network when we only looked at tribal organizations versus the network as a whole. So the tribal organizations were more densely connected than all of the organizations within the tribal public health system. We also saw that the Tribal Health Division had the highest degree centrality, so they had the most connections of any entity within the network, and they had the most betweenness of all organizations in the network. So they were most frequently the bridge between one organization and another organization. I have one of our network maps as the next slide here, which will probably be pretty difficult to read the little font on your screen, but the tribal organizations are pictured as circles and non-tribal are pictured as squares. And the organizations represent groupings of people who are within that sector. So it's not organizations, I'm sorry, it's sectors that each of these symbols represents. The larger circles or squares indicates that there are more people within that sector within the eco-map. Originally, when we put these maps together, we pictured tribal public health and tribal health care as separately, but through our analysis of the interviews and also through member checking, ended up combining them, because what we heard was that public health and health care don't see each other as partners, they see each other as members of the same entity, that they are both working on health, they are both in that same shared sector, that same shared space. So we ended up combining those. One of the things that we heard about and explored a little bit through the study was the relationship between tribal and non-tribal organizations within the network. And we heard a few things that we thought were important from non-tribal organizations. We heard about how they're nervous in their interactions about stepping on toes and that they don't want to be perceived as taking over a particular function within the public health system. We also heard that they believe tribal organizations are in the best position to serve tribal members, and there was also a recognition that services were underutilized by tribal members and some concern that perhaps tribal members weren't comfortable using those services or as comfortable using their services. From the perspective of tribal organizations, we heard that working with other tribal organizations sometimes is easier because they can focus on the needs of tribal members, and that non-tribal organizations have the responsibility to focus on the whole community. So while there was some difficulty, some tension between tribal and non-tribal organizations within the public health system, we also heard lots of powerful examples of successful tribal and non-tribal partnerships that accomplished some really important things for the community as a whole. And this is one of the quotes that illustrates that. I would go with the tribe, and what they're responding to is a question about key actors. So who are key actors within the tribal public health system or the public health system? And this respondent from a non-tribal agency said, I would go with the tribe just because they're very visible and they're very proactive and they're very up to date and they keep me on track. The people that I work with in the tribe, I think they're very forward. I think without them, I don't know how many initiatives would actually be occurring at the rate they're occurring. And we heard quite a bit of that, of the tribe being a driver of innovation, organization that brings in grants and resources and ideas that have positively impacted the whole community. So the second component of the model that we explored in quite a lot of depth was services. And we wanted to understand what services the tribe delivers and how. And we also wanted to understand the similarities and differences between the tribe services and the framework of the 10 essential public health services. So what we saw was that the 10 essential public health services and how they're operationalized through FAB standards and measures align quite well with how this particular tribal public health system educates people about health issues, diagnoses and investigates health problems, mobilizes community partnerships, engages with the policymaking process, and uses research for new insights and innovative solutions. However, there were some gaps for this tribe between the services they delivered and the 10 essential public health services, particularly related to enforcing laws and regulations that protect health and assure safety and assuring a competent public health workforce. What we also noticed was that there were some real sort of qualitative differences in the way things are done by this tribe and the way services are delivered when compared with the 10 essential public health services or FAB standards. What we saw was that the tribe's approach to assessment and planning was very integrated and very dynamic. And we saw lots of examples of it being impactful, but we also noted that it wasn't routinized. It wasn't something that occurred along a particular schedule or with a real specific sort of framework or product in mind. The tribe's approach to evaluation and quality improvement was different than the way it's described through the 10 essential public health services or through FAB, in that it really emphasizes the needs of the customer and values community wisdom. We also saw that the tribe's provision of community and clinical services was much, much more integrated than what would be suggested through FAB standards or the 10 essential services, that they operated hand in hand and side by side in a way that, that is different. We also saw that the services provided by the tribe are really designed to fit the tribe's sociocultural context. And this was a really powerful theme for us. I wanted to share a quote that kind of illustrates this idea. So culture, value, and traditions are honored in that we are trying to bring them back, bringing back that which was lost. For various reasons why they were lost, a lot of times people were not allowed to speak the language from what they were taught from our elders to have sweat lodges. There has been a lot of problems in history that have set us all off course, so to speak, and I think we are trying our best to give back our ways, our teachings in a good way, keeping in mind that it may not be the exact same that it used to be, but everyone is trying their best to honor our past, honor our traditions, and honor those teachings. We work for peace and we work for our tribe. We give back some of the culture that is lacking in a lot of things, and I know that it is not the tribe's fault. In fact, this I look at as a way to try to fix that. So this quote really helps illustrate how integral culture, history, and the sociological context were to service delivery within the tribe. So we looked at our data and we decided that what we saw was this set of public health services. Each of these, again, could be a whole webinar, and I think I'm running out of time a little bit here. So I'm going to read through these, but I also want to say that there's a lot of detail behind these as well, and I think a really interesting exercise was thinking about how public health services were delivered and what they did look like in this particular context. So the services delivered by this tribe were that they assure personal health services are person-centered, holistic, culturally tailored, integrated, and available to all community members. They design and administer culturally tailored community health programs to improve population health. They offer education and information to community members to engage them in health improvement, shift knowledge, beliefs, behaviors, and norms, and honor traditions and values. They build networks and engage with partners across systems to impact priority health issues. They monitor threats to health and plan for and respond to emergencies on tribal lands and across jurisdictional boundaries through the service area. They advocate for policy, funding, programs, and services that would improve the community's health. They assess health status around specific issues and develop plans to address community health concerns. They use data and best practices to improve services both for the tribe and through sharing lessons learned. And this quote that I have on the next page I think helps to illustrate what integration means and what it looks like in this context between public health and healthcare. The health centers are very visible and looked to for leadership. These health centers are much more than clinics. They do so much more traditional foods, traditional medicines, and public health promotion, tobacco-free awareness, and active and promoting walking. And they do contests where you get online and post the number of miles or number of steps for a period of weeks. And does your workplace outdo another workplace? They do a lot of that. And the health fairs where you can have your blood pressure checked and your oxygen content and your blood checked and read out your lung capacity and all of those things, and be aware of what your personal health status is beyond your annual trip to the doctor to pee in a cup. They do a lot here. It is a great source for the community, a great pride for the community too, because it is way more than a hospital or a clinic or a doctor's office. As we've gotten toward the end of the study, we've begun modifying the model that we started with to reflect what we learned, and we're hoping that this will, in a briefer way, summarize what we saw as the key components of this particular tribal public health system. So our next steps, we have been working with the tribe to use the data and findings to inform systems improvement. We've had over 5 working sessions with the data with the tribe where we've presented, discussed results. The data have been used by the tribe for strategic planning at this point. The tribal board voted unanimously to adopt a resolution approving the public release of the full research results in August 2015, which was incredibly exciting for us. And we're very grateful to them for their willingness to share who they are and what they do when it comes to public health. The board has requested additional presentations and products to maximize what can be learned from the study for improving their systems, programs, and informed planning. So we'll be developing those products and responding to that need articulated by the tribe as we move forward. We also have public products and publications that will be completed by October 2015. We'll be putting together a research report, a practitioner's toolkit, and a policy brief, and we will also be publishing a manuscript or manuscripts moving forward. So some of our ideas for future directions for research. For us, this highlighted the opportunity to have a research agenda that's buy-in for tribal public health services and systems. There's so much to learn, so much richness in this world, and so much we can learn both to impact and benefit tribes and to impact and benefit non-tribal public health systems as well. We think that there's a lot that we can learn through looking at the service delivery of public health and healthcare within tribes. We hear a lot about integration right now, and I think that tribes have already discovered quite a lot about both the benefits and limitations of an integrated approach to public health and healthcare delivery. We think there's opportunity to conduct additional research exploring the degree to which the 10 essential services describe what tribal public health systems do. We think it's an interesting and important way to look at services through a more emergent approach, looking at what they do and seeing how that could be articulated in a series of services. And we think there's opportunity to learn more about and utilize the practice-based evidence that's been generated within tribal communities to discover what works in tribal public health, where there is a real lack of evidence-based practice that's been tested in a tribal context. We think there's a lot of community wisdom that we could benefit from. Future directions from practice. For practice, we think that there's opportunities to explore we think that we should explore opportunities to enhance public health performance models to reflect the extent to which programs and services reflect and respond to the community's sociocultural context. We feel like that is a piece that's missing in the models of public health performance that exist, and for this tribe was absolutely critical and core to what they do. We think there's opportunity to support tribes that wish to develop public health codes, ordinances, and laws, or appoint a public health authority. And we think there's opportunity to explore financing options for tribal public health that decrease reliance on competitive grants and state-administered funds. Thank you for your attention today, and we look forward to commentary.
Thanks so much, Julia. We've got two folks scheduled to comment on today's presentation. The first one is Alana Knutson. Dr. Knutson serves as the principal research scientist and is the co-director of the Walsh Center for Rural Health Analysis, located at Newark at the University of Chicago. She's the deputy director for the Rural Health Reform Policy Research Center, one of 7 rural health research centers funded by the Office of Rural Health and Policy. She has 20 years experience leading health services and health policy research projects and also implementing and evaluating the impact of public health programs. So Alana, would you like to start us off?
Oh, thank you very much, and thank you for the wonderful overview of the study. It's always affirming as a researcher to have people who follow your research projects actually have similar findings. And I think I have some really interesting takeaways based on the work that we did. We completed this work doing a deep analysis of the tribal public health capacity assessment that was led by Lena Hernandez for NIHB, and I also want to recognize some of our key partners that were co-authors on that study, including Alina, Jessica Kronstadt, and Michael Meat. And this particular project was also funded by RWJ, and we're very grateful for that support because up to 2010, there had been no uniform collection of tribal public health data. And so that was the first opportunity to really look at what kind of tribal public health systems were in place. And as part of our analysis, we used the case control to make some comparisons between what we were looking at in terms of the different types of services that were provided in tribal health departments as well as local health departments. And we matched on geography as well as size for the local health departments and the tribal health departments. And just as a matter of comparability, 75% of the 79 respondents to that initial survey served populations less than 10,000, and they were primarily located in rural communities, so very comparable in many ways to the Bemidji service area, even though I know it's a little bit larger population, but clearly serving in a rural context. And similar to the findings of this particular study, we also found the tribal health departments were more likely to provide health screenings. They were also more likely to integrate behavioral health. And, you know, as was noted, much more integrated into the overall healthcare delivery system of the communities they served. However, we also found that local health departments of the same size in the same geographic areas were more likely to provide environmental health services, but as we were able to do some qualitative assessment, we found that many of those environmental health services were being provided within those tribes, but they were being provided in other agencies and other organizations within those tribal communities. So even though they indicated they weren't providing them, they were being covered by others. Likewise, I think it was really important to identify the issues about making sure that we find an opportunity to assure a competent public health workforce. We too found out through our qualitative component of our research that ensuring a public health workforce was a real challenge, and again, very similar difficulty finding people that have the requisite educational and training background, as well as the financial support to be able to hire people in those different positions. So I think we have a real opportunity as we look forward to supporting our tribal public health, looking for more opportunities to really strengthen that public health workforce. I also think it's important to identify some real positives, and I think this integration that our tribal communities have between public health and healthcare delivery is really important. And I think oftentimes we talk about health disparities and health equity, and we solely look at different types of health indicators. And I think sometimes we also need to really focus on our strength-based approaches. And I think tribes are particularly great at developing and supporting partnerships and collaborations. And I think many of our accountable care organizations and our new structures that some of our healthcare organizations are putting together to look at delivering more value-based care could learn a great deal looking at the integration of tribal public health, healthcare, behavioral services, and also social services. Because as was noted, there's a real emphasis in looking at a holistic support of an individual and not solely compartmentalizing them as solely a healthcare related issue or solely a public health issue. I also think it's very important to maintain the cultural preservation of our tribal communities. And again, as was noted, I think from our study, we also heard from the participants in our focus groups that they felt there wasn't often enough flexibility to be able to incorporate their unique cultural experiences and their unique cultural perspectives into their overall health systems. And I think as we go forward, we need to find a way to be able to capture that. And as we look at accreditation, also find a way to reward that and recognize that that is a very important underlying or foundational element that is unique to many of our tribal communities. And lastly, I think it's also important for us to think about ways that we could help in looking at finding some public health codes or overarching legal authority language that could be helpful for tribes that really are looking to codify public health. In one of our interviews, we learned that one particular tribal community was really looking to codify their public health, but they had a change in administration and a change in priorities, and they lost that window of opportunity. And they said if they would have had some model laws or model codes that they could have used, they would have been able to make better use of their time, being able to adapt or adopt language that other tribal communities had used to codify their public health activities and their public health work, so that these could be maintained over time, so that even as leadership changes, the public health work continues and is long lasting to support the health of the tribal nations. Lastly, I just want to thank the research team for taking a real in-depth look at one tribal entity and looking at all the different facets that contribute. When we look at surveys, we often don't have the opportunity to really get into some of the nuances, and I think this particular study really illustrates that there are some opportunities that we can use in our public health community to better support tribal public health, and also incorporate in any kind of our technical assistance, or as we look forward in looking at refining some of our evaluation criteria to really reflect that tribal culture. Thank you.
Alana, thank you so much. Our next person scheduled to comment is Robert Foley. Robert is currently the Deputy Director of Public Health Programs and Policy with the National Indian Health Board. He oversees a variety of programs providing technical assistance, training and resource brokering, and information dissemination services on methamphetamine, suicide, and HIV prevention, as well as tribal public health accreditation. He's worked with tribal, national, area, and local level stakeholders to assess and elevate tribal public health, the tribal public health platform. So, Robert, would you like to contribute?
Certainly. Thank you so much, Rick, and I want to thank MPHI as well as the tribe and all the partners in this research project, and I'd like to thank Alana for her insightful commentary as well. I was asked to provide some commentary on how this particular research and the results might apply to the public health field. And I want to add a qualifier that I think that this research project was conducted in a really good and respectful way, and in a high quality of partnership with the tribe. And so I think these research outcomes have value on their own, but honestly I think we can only begin to discover the true richness of this research when we begin to apply it and share these lessons learned with other tribes. And then I think we'll be able to see these outcomes bloom in a more fruitful way. I think that this project was unique in that it sought to paint a picture of a system that was, in all honesty, pretty well acknowledged anecdotally, but poorly described and not often captured in a very systematic way. So I think just the efforts by the research team and the project team to map out the scope and nature of the public health service delivery within the tribe is extremely useful. And knowing that that picture is going to be different, for the 566 other tribes within the country, I do still think that there are some general ideas that we can draw upon and things that we can take and that we can share that are going to be of higher level value to all of Indian country. And so in general, the research project, I think we can kind of boil it down to really beginning to understand the unique interconnectedness of public health in Indian country as distinct from other jurisdictions, and this has already been mentioned several times. So that includes looking at the different operating divisions within the tribes, the relationships that exist within external jurisdictions, that includes city and county, public health entities, as well as law enforcement and governmental entities that play a role in public health, and the presence of local public health nonprofits as well. Identifying those specific players, identifying and understanding the relationships that exist within the Indian /IHS/tribal/urban healthcare system. And those relationships aren't just always professional relationships. As was mentioned, that personal relationships play an extremely important role in public health service delivery, and the eco-maps presented, I think, begin to map that out. And I think we might even be able to take that to a higher level and begin to understand the trust and the rapport that not just exists, but need to exist between these various entities in order to create an effective service delivery mechanism. And then it was mentioned several times that public health and healthcare are highly integrated within Indian country and within tribal public health systems. And I think we can take this and tribes, and many tribes are actually beginning to ask themselves this question already, is this level of integration the best model for us? Or would it be more beneficial for us to continue to break apart public health from primary health care? And we're just now beginning to see tribes create their own public health departments within their health divisions and adding new names and moving apart from old systems of home health and environmental health and really beginning to create an identity for public health within the tribe. So when we ask, why is it important for us to understand all of these issues? Why is it important for us to map these out and understand these relationships and who those players are? I think there are some obvious takeaways. I think especially when you look at the eco maps that were created in this project, you can really begin to understand where best to access, not necessarily the community in this regard, but where to access the field. At what points in this network is it practical to insert workforce development efforts? Where is it necessary to strengthen or examine gaps in communication strategies? And at a prevention perspective, or I should say a programmatic perspective, who are the key players? Who are the significant players that would be the most effective in implementing key treatment, prevention, outreach, and education programs, as well as public health law programs, enforcement programs, and communication emergency preparedness programs. So understanding those communication channels that have been identified in this project, I think, are especially important when it comes to emergency preparedness and outreach efforts. And then understanding the key and influencing players within each of these tribal networks is going to be important in public health advocacy efforts. And that was mentioned by Alana, was also mentioned by Julia. What can tribes do in order to increase funding and create a more solid and consistent infrastructure? Understanding which players within the tribe wield, I use the term loosely, but influence, I think, can help advance advocacy efforts. And there are, of course, implications for coalition building, communication, collaboration, and partnerships, and that's especially key when we examine public health accreditation. As public health accreditation, coalition building and partnerships with external organizations is mentioned and emphasized several times throughout different standards and measures. I think when we begin to take some of these more superficial takeaways and peel away the layers and ask ourselves, what can we do that's deeper, more sustaining? What can we do that can have a greater impact throughout all of Indian country? And I think that we can begin to look at these 10 essential services and really shape them more as a guideline for Indian country rather than the gold star, knowing that the public health service delivery system in Indian country is different and unique. So we can take these standards and use them as a starting point. And I don't think any should be taken away from Indian country because they all serve a very unique and important function. But there are other areas that aren't explicitly mentioned in the 10 essential services, especially regarding traditional health, spirituality, and the connection to environmental health and behavioral health that is inherent in Indian country. I think the study actually identifies some gaps that currently exist within the public health infrastructure, and I think
Brian, are you still there?
I think we've lost his audio, Rick.
Okay, well, let's move on to questions. And so we've got about 4 minutes left. And Lori Chestnut had kind of a question and comment. Essentially, her comment is the lack of data sharing agreements between states and tribal public health systems or entities is a significant barrier to public health practice. Her question is, what can be done to help state and tribal public health partners develop and maintain these data sharing agreements over time? Julia, any thoughts on that, given your kind of what you found in your research?
In the context of this study, this particular tribe did not have the strong personal relationships with the state that they had with many of their partners within their local community and with other communities. So this is not a challenge that this particular tribe has found a solution to.
Great.
Hi,
Robert,
this is Robert Foley.
Oh, great. Go ahead.
Okay, I'll just continue my thoughts. I'm sorry, I got dropped.
Yeah.
But I was saying that there are some gaps that are identified, and I think that we can do some work to fill these gaps in, especially around the presence of state health agencies. And is examining the eco-maps, you see how far removed they are from the tribal health division. On some level, this is a positive thing because it describes the operationalization of self-determination by the tribe and their health division, and that's outstanding. But in other ways, the state health agencies can really serve as a positive source of resources for the tribe. And so what can we do to continue to strengthen that relationship and ensure that tribes have ready and easy access to the resources of the state? And I'm not just talking about funding, but I'm talking about services as well. And where can they partner around emergency preparedness, epidemiology and surveillance, disease notification, and services of that nature that many tribes don't have the ability to offer themselves. I also believe that media appears to be too far removed within the eco-maps. Media serve as a very important outreach and education tool and communication tool, and it's a vital communication channel in many tribal communities. And so what are we doing within public health to foster a relationship with tribal media outlets to ensure that they actually have a role to play in communicating and educating the community around public health activities? And then also, the nonprofit presence seems to be a little weak, as identified in this particular research project. We know that in the national scheme of things, nonprofit organizations play a vital and significant role in public health delivery, oftentimes bearing the brunt of a lot of the service delivery for issues like HIV, domestic violence, obesity, and chronic disease. So what can we do to strengthen the presence of nonprofits in tribal communities, whether that be build up and enhance the nonprofits that exist, establish some new tribal nonprofits, or invite other nonprofits in to begin to supplement what the tribe is doing. So I'm just going to end with some closing comments that there's an opportunity here, obviously, for workforce development and the ability to foster and funnel American Indian Alaska Natives into public health professions, and you can see the opportunities, the many opportunities within the public health system that exist for that to happen just by examining the results of this research project. And that's not to say that we should be excluding non-Native public health professionals. That would be extreme and an exclusionary measure, and I don't think anybody would advocate for that. But we do need to foster a tribal and Native presence in the public health field. I think that public health is truly community health in Indian country, and I think working towards impacting the behaviors through the combat of detrimental social norms and harmful stigmatizing perceptions is a cornerstone of tribal public health function. And I think more so than in the dominant society, we see public health in Indian country seeking to nurture a community spirit and fan the flames, if you will, of community identity and community pride. I think that that is something that we don't see captured within the 10 essential public health services, and I think that that is unique, and we see that in this particular research project. And so I would like to see how we can continue to foster that on a broader level and really begin to honor and celebrate the role that public health in Indian country serves. And so I'd like to thank the research team for bringing all of that to the surface and allowing me a couple minutes to comment on it. I appreciate it.
Robert, thanks so much. Julie, do you have any kind of final comments or anything you'd like to say before we end?
I'd like to thank both Elaine and Robert for your commentary, really insightful, important ideas and feedback that you added to enrich the discussion today. So thank you, and also for moderating us today. Thank you.
Thank you. Well, that looks like it's 1 o'clock, so please tell us what you think about the webinar series by clicking on the link to that survey that's on your screen right now. We have archives of all the webinars available at the URL down below. We have kind of a host of upcoming webinars that have kind of a wide range of topics, everything from randomized controls trials to increase adolescent immunization to building the evidence to improve the infrastructure of local public health through PBRNs. We've got a wide variety of topics coming up. But again, please, thanks again for being with us today. If you have some feedback, give it to us. For more information, please feel free to contact Ann Kelly, our project manager, at the email